which I've learned if you don't want to be on the recording, you're supposed to now log off. We miss not being with everyone, but certainly hope this time next year to be able to do that. In the meantime, the Planning Committee put together this webinar series, and we certainly hope that you enjoy it. A few housekeeping items out of the way. You know where your bathroom is. I'd like to thank our sponsors. ACOG District 12 has always been so supportive of our efforts here in Sarasota and in the region. And we'd like to thank also Drug-Free Charlotte County. This webinar series is being brought to you by the Healthy Starts of DeSoto, Manatee, Charlotte, and Sarasota County. Last week, and we will be having a webinar just like this every week for the next 4 weeks. Last week, PJ Brooks talked to us about the care and treatment of mental health and substance use disorders in the age of COVID-19. Today, we're very fortunate to have a group of esteemed experts who are going to talk to us about the Maternal Opioid Recovery Effort, better known as MORE. I'm going to introduce the 4 participants and let them get started. Dr. Bill Sappenfield is professor and director of the Chiles Center at the College of Public Health, University of South Florida. He also serves as a director of Florida Perinatal Quality Collaborative, as all of you should know, our statewide collaborative effort. Dr. Bill has taught me all the epidemiology I know. Betsy Wood is a registered nurse who retired from the Florida Department of Health as director of the Division of Community Health Promotion, where she was there for over 30 years. Betsy is retired in quotation marks. Early in her career, her clinical expertise was in labor and delivery in the NICU. Margie Boyer is a nurse consultant with FPQC. As I looked at her summary, the most important thing was that she was from the Ohio State University. She's had 35 years of OB experience. And then last, but certainly not least, is a colleague of many years, Lori Reeves. Lori is the program administrator and maternal and infant opioid prevention coordinator in the Florida Department of Health. We have gotten into good trouble over the years with her work with the March of Dimes. So without any further ado, I'll turn this webinar over to Betsy. Betsy?
Can you see my screen now?
Yes.
Yes.
Okay. Dr. Sappenfield.
Thanks, Betsy. We're so excited to be here as part of your regional summit. It really takes a whole community to take care of the needs of mothers and infants, especially now if we're talking about women with opioid exposure during maternity and afterwards. We are, as FPQC, we've been celebrating now our 10th anniversary, trying to work on quality issues, and this is one. And we are really excited about this initiative because we call it MORE, not just because it's a good acronym, because these women really need more attention, more support, more services, more follow-up, and more compassion. And we really appreciate this chance to talk about the work that we do with hospitals and providers, but in this initiative, the community is so important because you all provide a lot of the services they need. These women start in the community and they come back to the community. And so building a system that all women are taken care of is so important. Next slide, Laura. Betsy. Again, Dr. Hill's introduced all four of us. This is a dynamic team. I've worked with a lot of teams in my career, and FPQC is blessed with some real talented leadership and passionate people. Next slide. Opioid use during pregnancy. We have a Florida Pregnancy-Associated Mortality Review Committee. It's been reviewing all maternal deaths in the state since 1986. And in that process, we review the cases and determine causes and put out now these messages on important issues. And we just put one out this May that is really critical, and it relates to opioid use. Next slide. Opioid or drug-related deaths, see that red line that's there on the top right, is the leading cause of death to a woman during pregnancy and up to a year afterwards. There are more women now who die of drug-related deaths during pregnancy than they do preeclampsia, hypertension, homicide, motor vehicle accidents, suicide. It is by far the leading. About 1 in 4 deaths related to pregnancy. And that's a large proportion of our deaths, all of which should be preventable. And 75% of these actually occur after the baby's born and the mom goes home. So we know about these women. We know that they're opioid exposed, and we have an opportunity to make a difference. Next slide. Not only is it the leading cause, but here's the latest data during COVID. This is all the overdoses due to COVID. On the left on your screen are those that are fatalities, and on the right that are those that are due to EMS visits for drug overdose exposures. This is among women of reproductive or childbearing age. As you can see in COVID, the highest monthlies were up to 100. And right now you can see in May it got up to over 120. And then you see this drop off. Well, that drop off is a mirage. That drop off is due to reporting. The only reason why it falls off is it takes about 4 to 6 months to get most of the deaths reported. So projections are that these deaths are going even higher than what you see in this graph. To support this, on the right-hand side, this is what EMS has responded to across the state in terms of drug overdoses. And this is again among reproductive age women. And you can see we've had a large increase. So we have the leading cause of maternal mortality in Florida, and it's only getting worse during COVID. Next slide. And being the leading cause, I know Betsy's trying to get it to work. Leading cause, it now gives us what we call opportunities. These deaths are truly preventable. And there's 2 key ways that we can absolutely prevent these deaths. We are now trying to mimic 2 other states who've worked on this, Massachusetts and Illinois. They are now up to over 70% of these women being in medically assisted treatment by the time they're discharged from the hospital. And in Florida, for the hospitals we have data on, we're at 28%. So we have a huge gap of women who need to get into a drug rehabilitation and behavioral health. Also, the other thing that's very important is these women, when they go from the hospital, home from the hospital, need to be on naloxone. They need to have access, them or their loved ones. And they need to be educated on how to use it. In Florida, we're running right now with only 18% of our moms going home with naloxone prescription or having it in hand and knowing what to do. So these deaths are a chronic disease, but in fact are highly preventable, and we just need to act and help provide more to these women. Next slide. I call this a step up because this is where all of our OB providers and hospitals have a chance to know who these women are, and working with our community partners, we should be able to wrap ourselves around these women and help those women who want support. We need to screen all women for drug use. We need to refer them into both obstetrical and medically assisted treatment. And we need to be compassionate and understanding and really trying to help support the women as they deal with this chronic disease. We're so pleased to be here. The community system is so important, and we look forward to having ongoing discussion. Betsy?
Thank you, Bill. Can you hear me?
Yes.
Oh, good. I wasn't sure if I was on mute. So we began the maternal opioid recovery efforts in November of 2019, almost a year ago. We have 23 participating hospitals around the state, including 3 hospitals in your region. You've got Sarasota Memorial, Manatee Memorial, and Bayfront Health, Port Charlotte, are all participants in our MORE initiative. So thank you. Here's a picture of our kickoff, which was very, very well attended. We just had our mid-project meeting. It was our first virtual meeting that FPQC has done. It also was well attended. It was, I guess it was last Thursday. And so people from other states shared some of their lessons learned. We were able to go into round robins, breakout sessions where people throughout the state shared strengths and their weaknesses and their successes and their challenges. And hopefully everyone came away re-energized and ready to really focus the effort back on maternal opioid use disorder. This is, I love these things. This is called a key driver diagram. And it really lays out the entire initiative in one piece of paper. So the global aim is to improve identification, clinical care, and coordinated treatment and support for pregnant women with any opioid use and their infants. Our aim, which is a measurable aim, is that by March of 2021, at least 50% of pregnant women with any opioid use will receive screening, prevention, and treatment services. And as Bill said, we have not hit those numbers yet. So we identified 5 primary drivers, including screening, prevention, treatment, comprehensive discharge planning, and then the hospitals needed to really focus on policies and procedures in order to move the initiative forward. And then the secondary drivers are really the recommendations. If you put these steps into place, they will affect the primary drivers, which will then affect the aim. One of the main key components of really dealing with pregnant women with opioid use disorders is to identify them. And so it's really critical that we have early screening of all pregnant women for substance use disorder. We've identified 3 tools and put them out there to our MORE hospitals, and the majority of the hospitals have adopted the 5 Ps screening tool. And we actually need the community's help to not only have it happen in the hospitals, but to push it out into community OB providers so that on their first prenatal visit, they don't just get the question, do you use drugs? They get a more comprehensive screening tool, verbal screening tool, that then can identify women at risk for opioid use disorders, and then the provider can delve into it more. And, this is an SBIRT card, screening, brief intervention, and referral to treatment card that we developed for our providers. The front talks about the risks of substance use in pregnancy, and then the back of it really talks the providers through that conversation. Another of our recommendations, our secondary drivers, is to refer all women to follow up with behavioral health and medication-assisted therapy. We've developed algorithms for use by the prenatal care providers. We have one for labor and delivery. This one is for prenatal care, and then we have one for an antepartum admission. And it just walks the provider through additional screens that are necessary, and then what kinds of referrals are necessary to provide the comprehensive care that these women need. Under the prevention, really, we're focusing on reproductive life planning. Up to 72% of women with substance use disorder have not planned their pregnancies. And so this is a conversation that needs to happen actually prenatally, but then also in the hospital. We're focusing on breastfeeding initiation and rooming in rate under the treatment section of the key driver diagram. Then we're really focusing on comprehensive discharge planning, including the postpartum depression screening. The OB postpartum visit really needs to be not at 6 weeks, but closer to 2 weeks to a month for women, just to check in to see how they're doing. It's such a high stress time, bringing a newborn home, especially for the first time, and then also dealing with getting your medication-assisted treatment, lack of sleep, and as Bill said, the relapse and the overdose issues among postpartum women is alarming. And so we really need to keep them plugged into their system of care. Again, make sure that behavioral health or MAT visits are continuing, or if it's a newly identified woman with opioid use disorder, that there is a referral made and a warm handoff done. The Narcan counseling is critical. We are working with the hospitals to actually have the women go home with Narcan, with a Narcan kit, either for themselves or for their significant other. Again, because of that issue with overdose. We need to make sure that social work consults are happening, the pediatric consult is happening, again, comprehensive contraceptive counseling, and that home visiting programs or case management is plugged in so that women have the resources that they need when they get home. And then we also include a patient education bundle. We've developed video series, a 4-part video series that's available on the FPQC website. It deals with, and they're very short videos, between 3 and 7 minutes long. One of them deals with the impact of stigma. One of them is 2 women in recovery who are really talking to women who are contemplating admitting to their drug use and also thinking about getting into medication-assisted therapy. The screening, break intervention, and referral to treatment, that SBIRT video, we looked all over the country and we really couldn't find a video that demonstrated how to do an effective SBIRT session. And so we filmed one ourselves, thanks to Halifax Hospital and Volusia County Healthy Start Coalition. And I think it's really very effective and very impactful. And then the 4th, we deal with plans of safe care. So the next thing that I want to do is show you one of the videos.
I was afraid of so many things when I came to this hospital. I was afraid DCF was going to be called. I was afraid they were going to take my baby. I was afraid that I was going to go to jail. I was afraid they were going to rip me away from my life and send me to treatment far away.
So 6 years ago, I went to the hospital to have my daughter, Raina. I had substance use disorder. The staff knew that I tested positive for substances. I was afraid that they were going to take away my baby. They called DCF. DCF did come and they did take my baby out of custody. So from that point, I had to engage in services. I went to drug court, and drug court at the time I thought was the worst and most uncomfortable thing that I'd ever done in my life, but it turned out to be the thing that saved my life.
Taking the first step is definitely the hardest. Asking for help, that's the ripping off of the Band-Aid. And everything after that is the healing pain.
Once I realized that I needed the help that they were giving me, I had an opportunity to focus on myself and become the mom that I wanted to be.
It's painful. It's not easy. Nobody ever said it was easy, but it's doable, and there's hope.
It was actually the wake-up call that I needed. It was the only opportunity I was going to have to actually seek the help that I needed, because I didn't know how to ask for help, and I actually needed that thing to happen so that I had the opportunity to actually engage in help.
Eventually had a doctor say that she believed in me and saw potential.
But there was this one nurse,
and I trusted her enough to tell her that I was using drugs.
That at one point told me, I know you're going to be a great mom.
And we worked together.
And I held on to that because that was the first time I actually felt hopeful.
And 6 years later, we're still friends. It takes a lot of hope.
If any of this sounds familiar to you, give yourself a break, give yourself a chance. There's help out there if you need it. You're brave, you're strong, you're loved.
Okay, so Margie,
Yes.
take it away.
Thank you. Thank you, Betsy. Every time I watch that video, I just tear up, and it was a beautiful experience. And again, thanks to Halifax, Volusia, Healthy Start Coalition, and Lori Reeves on putting that video together. It's been such an impact in all the areas that I've sent it to. And there is a direct link on our FPQC website under the More project. We can show you that if anybody needs help with that. So I'm going to talk a little bit about the outreach material that I work with Lori Reeves and the Healthy Start Coalitions on getting these materials out to all of the Healthy Start Coalitions across the state. And one of the first things is for those doing the office visits to make sure that the offices have the posters. This is a poster, and I have one next to me. It is this big, so it's a huge poster that goes in their offices. The target audience is for prenatal care providers. The purpose is to increase understanding and build capacity for identifying and addressing the needs of moms with opioid use disorder. So this is a quick reference that the OBs and the nurses and the providers can look at in the offices to remind them the importance of screening women and getting them help. Next slide, please. And then we worked on some other pamphlets that we sent out along with the poster to the offices. So one of them you've seen, Betsy went over, and that's the SBIRT. When we got feedback from the providers, they really liked these pocket cards. So these on the left, the SBIRT, the sample script for brief intervention, they can carry those in their pocket, in their lab coat, refer to those as needed. Just as more of them are learning how to do an SBIRT, they found this to be very helpful. And this again is for the providers. The next thing we made sure all the Healthy Start Coalitions had was a direct link along with a QR code. This was a handout we got to all of the Healthy Start Coalitions on the 4-part video series. So the one that you just saw. Next. And then we also sent to the Healthy Start Coalitions the Language Matters. This is also for offices, again, making sure that the provider offices, the staff, everyone that works in the offices understand the importance of language, what to say, what not to say to a woman. So it gives them key points to look at, and just as a refresher, just at a glance. The other thing we gave Healthy Start Coalitions to get to the providers is the Narcan how to prescribe, because many providers struggled with exactly how to do it. So this we took from the Illinois Perinatal Quality Collaborative with permission, and it's how to, again, how to prescribe Narcan. Next slide. And then this on the left, again, we felt it was so important to have. This is a trifold. It's all about how to use Narcan. And this is a guide for both patients as well as their caregivers. Most importantly, those caregivers need to know how to administer Narcan. And inside, again, we have a picture of the nasal spray, which is the easiest, the kits that many of the hospitals are working through DCF to get those kits to give to everyone, especially to the care providers for women exposed with opioid use disorder. And then on the right is our More Hope pamphlet. We worked with Healthy Start Hillsborough to create this pamphlet. We already had one for NAS, and this one focuses on the mother. We really couldn't find a really good all-in-one packet. And this is called the More Hope, and this is what the brochure looks like. And it focuses on prenatal, it focuses on interpartum, focuses on postpartum, and then a little bit on the baby. And in the back of this pamphlet is the code to get directly to the video that you just saw. So if you give this to, the provider gives this to the mom, then they can look through it and refer to that same video we just watched. And I think, next slide. Oh, I think I handed off to Lori.
I have to unmute myself or you won't be able to hear me. Thank you, Margie. And I just want to circle back for a moment to what Dr. Sappenfield was saying at the beginning of this session about maternal mortality, because one of the biggest issues and challenges that we have with women with opioid use disorder right now during this pandemic is there is a higher risk of overdose deaths. And we've seen the data for Florida. It is preliminary, but it isn't good. So those are the slides Dr. Sappenfield showed you early on. So how does this connect at a community level? What do we do locally to try and help prevent maternal deaths and get more women into treatment during pregnancy and hopefully reduce the number of babies with NAS as well? So we understand when we're doing an initiative like MORE, which is a quality improvement initiative at the hospital level, that this particular initiative is very complex and hospitals can't solve this problem alone. So one of the things we did in the first 6 months of our work on MORE was go out and visit communities. And I was privileged to come down and visit a couple of communities in your part of the state. Also visited communities in all of the areas of the state that had hospitals participating in MORE. And one of the things people struggle with is trying to find where there are resources to refer women to. So at the hospital level, or even if you're at the county health department or you're a service provider in a community, I heard a lot from obstetricians about struggles with this. Just knowing where to find resources was hard. So we are working with Healthy Start to assist hospitals in the MORE initiative to map out those community resources for their communities. And some communities have done this already and have done an extraordinary job. Those that aren't finished yet are working on it now. I know in Sarasota, they've started Unite Us, and it's in surrounding counties as well. And they're building some pretty interesting and innovative ideas into that model for referral. So there's a lot going on with this. And I hope if you're on this call that you are already connected with your hospital and your community as a resource so that you're included in the mapping and people are aware of what kinds of resources and support you can provide. Next slide, please. When we talked with communities around the state, there were some obvious challenges at the system level and some local barriers as well. COVID-19 clearly has created all kinds of new complexity. Some of the things that have happened since COVID-19 have been good. There is more flexibility in telehealth access for people with substance use and mental health disorders. That is good. But there were gaps in talking with providers of behavioral health services, for example. In some cases, there were gaps of as long as a month in communities where they weren't taking new patients while they restructured themselves so that they could provide services in a different way and a safe way during the pandemic. So there are better ways to provide care in some cases, but we may still be missing people and we may have missed some opportunities when services were not available. One of the availability issues is common to almost every community we visited, and that is they don't have enough providers for MAT. They talked about not having enough people who have the X-waiver training to prescribe buprenorphine, that it's very difficult to get prenatal care for women who have substance use or opioid use disorder, and that many OBGYN physicians are reluctant to care for these women in many cases because they don't feel confident that they have a support network of services that can help them provide good care for women with substance use disorder. So they want to know for sure. One obstetrician I was talking to said she wanted to do more, but she didn't have anybody with expertise in social work on her team, and she needed some help knowing how to connect immediately with behavioral health services so that if she implemented SBIRT and had a patient who was positive, that she had a way to immediately connect that patient with support and care. So we're trying to help at the community level identify opportunities where we can make better connections, and we think the mapping will help with that as well. Access to care, Medicaid is a benefit, but sometimes also is a challenge. Many communities said that they had trouble getting reimbursement, or they had trouble finding Medicaid providers who actually would care for women in their own community, that there might be providers that were on the list, for example, but that when they tried to schedule patients with them, they hadn't finished the certification process for Medicaid or other kinds of challenges that they ran into. So it's never as simple as it seems like, is what people said. It should be anyway. Next slide, please. And one of the biggest barriers is stigma. And it's not just stigma in the healthcare community towards people who have substance use disorder. People with substance use disorder are dealing with their own issues with stigma. And one of the reasons that we created the video Getting Real, which is of the 4 videos in our series, that one is specifically supposed to be woman to woman. And that was to help women who were afraid to accept services because of so many fears about what that's going to mean. That was designed to have women who are in recovery speaking directly to them to talk through what the terrifying, challenging things are and how they got through it, and to project hope into a situation that is terrifying for most women. People who need the help are often the most difficult to engage, and that can be for many, many issues. And then another issue we found in visiting communities was funding. So peer navigators came up repeatedly, that communities were aware of the value of having peer navigators to work with women in this community, but that they had piecemeal funding, and that they might have a grant that funded them for 18 months or 2 years, and then they would have to find another grant or other funding source to continue those resources beyond that time period. And that meant sometimes they would not have money for a period of time. One county had to lay off a couple of peer navigators. A few months later, they had money again to fund peer navigators, but then they had to hire people all over again. And so it creates service gaps, and that's a challenge at the community level. Next slide. So we started a couple of initiatives at the state level that we're hoping will help us address some of the gaps. One of them is for plans of safe care. So a plan of safe care, the regulations around that beginning in 2018, it's required. However, it usually is not triggered for a family until there is an infant born with substance exposure. And what we want to have happen is increasing the number of pregnant women who get a plan of safe care before the baby is born. And that will help her establish a system to take care of her needs before delivery, get her into treatment, make sure she has the right housing and other support services that she needs, and then have her prepared for the conversations that may or may not happen with DCF at the birth, at the hospital, etc. So it would help the families be informed and prepared, help the moms be ready. And help us address the fear about overdoses by keeping women in the system of care, both before delivery and after. So we're going to do a pilot project at the state level. We don't yet have a specific start date, but we're going to look at incorporating plans of safe care into existing data systems and see if that's effective, and that would allow us to have a new model of starting plans of safe care for pregnant women. So there's more to come about that in the next couple of months. Next slide, please. Whoops, jumped one. There we go. And we're also going to be looking at messaging around plans of safe care so that people in different settings know how to interact with women who may need a plan of safe care. So not just hospital settings, but also outpatient settings. For example, in an obstetrician's office, what would the nurse manager there say, and so on. And then we're going to put together a framework of recommendations. And then the next thing that's not on the slide, but we just started, is an MAT work group. So we're working at the state level to try to identify system barriers to accessing MAT. And one of the things that's come up during the pandemic is that even though in February, the Agency for Healthcare Administration released a memorandum stating that the prior authorization for buprenorphine was waived for women who are pregnant, the pandemic came along right after that came out, and in many cases, there has been, it hasn't been embraced universally. I think there are a lot of organizations that are still not 100% aware that the regulations about prior authorization have changed. So we've put together an MAT work group, and we're also going to have a separate group of OB/GYN physicians and nurse midwives looking at how to provide the right support so that physicians doing prenatal care are also able to refer women appropriately for MAT during pregnancy, or in some cases provide that MAT themselves directly at their offices. So there's more to come, but all of the stuff that we're doing, I just want to emphasize it's because people in communities have told us this is the kind of support that they need. So we hope that it helps the hospitals be successful at more, and that it helps communities be more engaged in that work as well. Thank you so much. I think we're at questions now.
We have questions.
Questions, and some questions I think I see in the chat. First of all, I want to thank the four of you for, again, really informing this group and others as you have done on this initiative. A couple of questions have come up, and that is the more initiative provider outreach materials. Where were they distributed to? And if someone wants them and can't find them or didn't get them, what are they to do?
I think I can answer that, and Lori can chime in. Those all went to the executive directors for the Healthy Start coalitions. Betsy and I and Bill and FPQC team got together, asked how many every coalition would like, and then based on budget and the funding from ASTO, we were able to provide each coalition a huge supply of all the pamphlets they needed. And then there is an ability to download additional ones on our website.
So each ED for the Healthy Starts, and I've been told there's a Healthy Start in every county, received them for their area, and then they were to get them out to the various practices, I assume,
Yes.
clinics,
Yes.
hospital,
That was the
ED,
intent.
whatever.
Yes.
Is that a correct statement?
And
So-
again, all the material for the MORE initiative is up on our website, including these handouts, including the video. We have put them in the Zoom chat, Dr. Hill, so that people can go to those websites and get that material. And if they cannot find it and they need help, just email us at fpqc.usf.edu and we'll help you, because we don't want you to have problems not finding things.
Well, what I see in the chat is some of the places do not yet have them. That may be an issue with them not yet out of Healthy Start. or whatever, but I just want to make sure that everyone knows where they can get them. And when we ask if they are in a clinic, I'd like to hear yes, they are, versus I'm not sure. So I think.
And if we have more requests and you really, really need them after you've tried to get them through the Healthy Start and you run out, let us know. We can always try to see if we can get more funding for more printing. I don't think anyone wants this initiative to fall short because we don't have enough copies. Again, the problem for us is when we mail things out is just figuring out
Yes.
we can't mail to hundreds of places.
You never know where they're going to go.
Dr. Hill, this is Sarah. We do have some at the Healthy Start Coalition in Sarasota. I put my email address there in the chat. If you would like to receive a set of the materials, I can get those to you.
Sure, we can talk offline about that, sir, and I thank you and Sean. And I think some of the questions came from other Healthy Starts as well.
And the intent of the materials is not only get them out to the community providers, but also to get them out, be honest, to the doctors and others. That's really one of the points of contact we need to start to educate, and we know that's a challenge.
The other question I saw in the chat is whether or not this type of presentation is available as a grand rounds at an institution through Zoom.
Absolutely. Just we still are able to do grand rounds. We're funded to do that. What we usually do is we do a pre-visit talk to make sure we hear what people want, and we do things based off of where they are and what they want. Betsy and Margie have done quite a few of those, and we haven't done as much with COVID, but we're able to do them if people are interested.
Very good. Linda here in Sarasota asks, is there a direct link to the SBIRT video? I think the answer.
Not a direct link. The link that's there sends you to more. And if you get onto the more webpage, once you click on that, if you go down to video snippets, it's a box down at the bottom of that website. You click on it, you can see the 4-part series, and all 4 parts are there. So again, there's a more link that Sarah put out and I put out. You click on it, you go to the bottom of that website page. There's a video snippet box. You click on that box, and then you can see what's there. And you'll also see some of the other materials that we have.
Very good. And you've given the website several times. Any other questions? Do you see any in the?
We want to hear all the barriers and hear all the possible solutions. We are looking to figure out what it is. We also know that some of them are going to be statewide and some of them are going to be local, but we are trying to figure out what is it going to take to create change, because that's our whole goal, is to create change in the care of these women.
One of the things, Sarah, if you can take a look at the chat while I mentioned something to Bill. One of the things that you mentioned at the very beginning is that, and of course doesn't apply to anyone here, is that we need to be really compassionate when we talk to these patients, because it's taking them frequently a while just to get in to see us. That's why we see them at 28 weeks gestation. And if we can't be sensitive and compassionate and empathetic with them, they're going to be turned off, and we will eventually see them again when they're in labor and delivery, and that's not what we want to do. I'd like to hear one of the nurses also comment on that. Lori, what did you hear as you went around the state in terms of empathy and compassion and the delays that these patients have in seeking prenatal care?
Well, I'm not one of the nurses, but I'll still.
When I said that, but you're good, Lori.
Thank you. What we heard was that a lot of times, even if they were offered services, they declined. And one of the things that I heard was people don't really know how to have the conversation with women. and they're a little bit afraid themselves of broaching the subject and talking about it. So when we were putting together our videos to train nurses and office staff on plans of safe care and SBIRT, we incorporated some role plays with motivational interviewing techniques. And especially the one for plans of safe care has some real specific learning objectives around motivational interviewing that I think can be helpful, because one way I've heard it said is, it's one thing if you say to a woman who comes in and is doing her little checklist as she checks in for her office appointment, and you say, are you using any substances like tobacco, alcohol? You know, that sounds very judgmental, as opposed to saying to women, a lot of women in our care have struggled with substances that they were using before they got pregnant. And we have support services that can help them with that issue. Do you have any substance use issues that you need help with, et cetera? So it's all about how you have the conversation so that it is less judgmental, more warm and welcoming. And remembering, as Dr. Hill, you said to me a year ago, you know, that substance use disorder is a chronic disease, and you shouldn't treat it any differently than you do a woman who has diabetes in pregnancy. You wouldn't send her away with blood sugar that was out of control. You should not send a woman with opioid use disorder away without treatment and a recovery plan.
Betsy, Margie?
I would just add,
Your years of experience?
yeah, I would just add to go along with what Lori said, and Betsy and I have talked a lot about this. As an L&D nurse, we always ask that one question when she came in triage or OBED, do you drink alcohol, or do you take any street drugs or prescription drugs or non-prescribed drugs? And that was it. And so, and then there was a little bit of stigma going on. So we've had to retrain the L&D nurses about the 5 Ps, and many of them now have that incorporated into EPIC or Cerner. So that's a big help. So the 5 Ps are right there for them as part of our initiative. But we've had to do a lot of training around stigma. And now I'm teaching nursing students. So we watch the stigma video, and the dialogue, it still goes on. So we have to continue to work with the nurses and providers on how to be more compassionate and look at themselves as far as that stigma goes. So it's a process, and I think we're getting there because we have a lot of discussions around it. Even on our coaching calls, we talk a lot about the stigma. So there's more work to be done, but it's come to the surface, and I think definitely we're improving.
And the other thing, if you're not familiar, it's called trauma-informed care. Most of these women have had major life traumas, and that's why they're in the situation they are. Our website has some training out there on trauma-informed care, and we just had an excellent presentation by Dr. Ann Lewis O'Connor from Harvard at our mid-project meeting last week, and the video is being put together now, and we'll be sharing that out to Dr. Hill and others. It's only a little over 30 minutes, but it really gives you the idea that you really need to totally rethink how you approach. Gloria is right about motivational interviewing, but it also, you just need to realize that these women are traumatized, and how you approach them and how you enable them instead of investigate them, enable them and empower them is going to make all the difference. So please, if you're not familiar with what we're talking about, it's something that you really want to learn.
One of the things, and then I'll give Betsy an opportunity, at our conference last year was, and we always have this, is we had 3 women who told their story. And it's amazing, as Bill just mentioned, when you listen to the trauma that is going on in their lives, that they're even sometimes alive. And then you hear the story and you can see where they got involved with substance use. Betsy, in your years of experience, would you like to make a comment, please?
I think that most of my points have been covered. I did just want to reiterate that we do have several videos. We've got an educational series on the MORE website that there's a whole session on trauma-informed care. There's a session on motivational interviewing that some of our teams have looked at and said that it has really helped them in their whole culture within the hospital unit. And so I would encourage folks to look at that as well.
I think it's important for us to realize that we all have biases and implicit bias. And we had a patient last year who had two babies. One, I want to say 2 or 3 years ago at our institution. And I don't mind saying that. And she said she did not feel comfortable. But then she more recently had one and she felt far more comfortable. And a lot of the change had been because of the training of the nurses, the more compassionate interviews, the recognition that indeed we all have implicit bias and that we have to try to deal with them. Sarah, did you see any other questions in the chat? We have 8 minutes left.
There's a request for a presentation. And then just to let everyone know, the video as well as PowerPoints will be available on the Healthy Start website and YouTube channel. So that can be viewed later as well.
If someone has would like to unmute themselves, you're welcome to unmute and make a comment.
Good afternoon. My name is Shirley Perotto. I'm the Director of Health and Safety and Outreach here at Lecom School of Dental Medicine. Thank you so very much for the great presentation last week and this week. I would like to invite whomever would have this type of information, if you would like to at some point provide via this same virtual method information to our students, our dental students. I have a student right here in the office with me. We're working on some other projects. And one of the things that I said to her was, what happens when you have a woman who is pregnant come and you might suspect that they might be utilizing meth, alcohol, cocaine, whatever it may be. What is our approach? What is it that we do? So on and so forth. And she stated that she has a series of questions that they go through and like a checklist. But it would be great to be able to provide, because a lot of times what I say is that those of us in higher education may work within the community, with the community. However, it's so important to have the community, those who are boots on the ground, like I like to say, talk to our students in training about the realities of what happens out there in the real world, which is very different from textbook. Thank you.
Well, I'm sure that we can reach out to you. If you want to reach out to FPQC, we would be happy to share information. And while I have you, I'm going to thank Lecom for the times when we've had someone who really needs something and pregnant, and I got a sore tooth, and I've tried 5 offices, and you all have been willing to do that. Thank you so much. Anyone else want to unmute themselves and make a comment or question?
Margie, we had a request for those materials are on the website. Is there any way you can download some of those and send them in an email to Sarah, and Sarah can send those out to people by email?
Yes. Yeah, Sarah, I'll email you those. I'll download them and send them to you directly, Sarah.
That would be very helpful. When I reach out to someone, I say, here's the link where you can get the materials, not only the link, but also that they are at Healthy Start. So as you know, it's very hard to get these materials in the right hands and on the right desk and then distributed to the right clinic, right? And we've done a lot of hard work here, and we need to just continue to work harder on getting the material out. Any other comments from the participants or anyone who's on the call? Don't be bashful. I've never known this group of healthcare providers to be bashful. Well, hearing nothing, we may be done a little bit early. I want to thank the 4 participants, all of whom are colleagues and friends, and I want to thank all of you who have worked hard on this initiative. We have come a mighty long ways. I can remember when we first had this discussion 5 years or so ago at our institution and at others, and things did not go so well. But I know that things have gone a lot better in recent years, and a lot of it is because of the hard work and the sincerity of many of you out there. Just keep up the good work. Well, last week we heard from PJ, and we appreciate the very positive comments. This week we heard about the MORE initiative. Next week we're going to hear about COVID-19 and pregnancy, and I would encourage you to join us. When I grow up, I want to be able to give a talk like Pat Duff. Pat is an expert in infectious disease and just a very wonderful speaker. The following week, we will be talking about the first 1,000 days of Sarasota and what you can be doing in your own community in regards to uniting your referral agencies. And then the last talk will be by myself on marijuana, CBD, and vaping. I want to thank you all, and I want to thank again the sponsors, ACOG District 12, and thank Charlotte County Drug Free, Charlotte County, and then remind you that this program is presented by the Healthy Starts of Sarasota, Manatee, Charlotte, and DeSoto County. I want to thank also Sarah Olson and our technical crew. We appreciate it. Thank you very much, and have a good rest of the day.
Thank you.